their like quality of sleep is good, and it's actually considered as a benign snoring. So now it's being recognized that snoring is not benign, and it can cause a lot of health consequences actually. And one of the health consequences which has been noted along with snoring is the increased incidence of fatty liver. So in one study which was published in Nature, where they have studied around 5,000 individuals, they have found that people who snore have a two times more chances of developing fatty liver. And this association they have seen not only in obese patients, they have seen even in lean individuals also. In fact, this association of snoring and fatty liver was more stronger in the lean individuals whose BMI was less than 24.
Is this snoring, do you think that it's only a mechanical effect of the person's spouse or whoever is sleeping? Do they have any health consequences because of snoring? Is it?
So, a lot of studies have proven that people who have snoring have a higher incidence of sleep apnea, that is impaired breathing during the sleep and dip in the oxygen levels during the sleep actually. In fact, in our own study which we have recently conducted, in an online survey which we have conducted actually, among 800 people who have responded to the survey, we found that around 400 people have snoring. And when we used a specialized questionnaire to assess the risk of sleep apnea in the patients who snore, we have found that around 50% of the patients who snore had a risk of severe sleep apnea, and around 30 to 40% more had a chance of having a mild to moderate sleep apnea. So around 90% of the patients who snore have a risk of having a sleep apnea. So that, and as we know that the sleep apnea has got different consequences, health consequences.
So ultimately there is some relation between the fatty liver and snoring.
Yes, sir. Snoring leads to increased prevalence of sleep apnea,
right.
And then sleep apnea indirectly leads to increased fatty liver. As we know that in patients who have sleep apnea, there is a nocturnal oxygen dip which leads to insulin resistance 1, and that leads to oxidative stress, inflammation, and also there is an alteration in the liver lipid metabolism.
So is the quality of life is different in these people who have these sleep apnea syndromes? Next day, do they feel fatigued and things like that? Does it?
Yes, sir, the quality of life is very much impaired actually. They wake up just with a tired feeling, and then during the daytime they have an impaired concentration, impaired mood, and at driving actually they have an increased chance of accidents. Not only these things, actually their work efficiency is decreased during daytime, and they have a higher chance of having a sudden heart attacks, sudden brain strokes, and increased chance of diabetes and increased chance of hypertension. In people who are already diabetic or hypertensive, their diabetic control or the hypertensive control is impaired. In fact, they say that if a person is on more than 2 antihypertensives, we should suspect strongly sleep apnea in a person and then check for that. And if you identify sleep apnea in uncontrolled hypertensives and treat that, the chances of their requiring number of antihypertensives decreases and their blood pressure control gets better as well.
Okay, Vishnu, but how do you really test it? We just ask the spouse how long he snores in the night. Do you have any tests for that one?
So for all the clinicians who are watching this, and also for the general public, we have a small simple questionnaire which is called as a stop bank questionnaire. In that we ask for snoring and tiredness. T is for tiredness, whether the person is getting tired after waking up in the morning, and observed apneas, if they're having any cessation in the breathing, if they're having any choking sensation in the night time, and if they have a blood pressure. P stands for blood pressure, stop, and bang is for body mass index, which is more than 30, and age more than 50, neck circumference which is more than 14 inches, and then also the gender. Male people have a higher chance of having sleep apnea. So you look at this small questionnaire in the OPD, and if you feel that if a person's score is more than 2, then they fall into a risk of sleep apnea. In these patients, we try to do an sleep apnea study. Basically, we do a sleep study in which we measure the oxygen levels, the pattern of breathing, and all those things, and check whether the patient is having sleep apnea or not.
Okay, having done it, of course, not only we just have a cardiology and pulmonology here, other systems are also involved, especially PCOD in young girls, and then that causes a lot of menstrual abnormalities. And even kidney is supposed to be involved in the long run. The kidney problems also occur. And many times, we, as a part of the treatment, we prescribe the statins. Narasimhans, many people feel that the statins, there is a little bit of feeling about the usage of the statins.
So yes and no, because part of the reason is statins are extremely effective in preventing a plaque rupture, an unstable plaque rupturing. The plaque gets stabilized within the coronary artery carotids. But the problem is the denominator is so huge, you need to treat a large number of patients to derive the benefit. So nowadays, when you find that the patient is slightly at a higher risk, there are better risk stratification scores which simply involves looking at calcium in the coronary artery. So there is something called power of 0. If there is no calcium in coronary artery, then the risk of this person developing coronary artery disease or sudden cardiac event is extremely low. So in patients with the intermediate risk where we are not able to decide one way or the other, we use two parameters. One is we look at whether the patient has inflammatory markers. Simple thing is high sensitive CRP, and second thing is whether there is any evidence of atherosclerosis. It can be either coronary artery calcium or carotid IMT. If intimomedial thickness in the carotid is increased or high sensitive CRP is increased, these patients clearly benefit from statin therapy.
Of course, the message is that the people with the NAFLD also have a lot of metabolic diseases like cardiac and also diabetes along with obesity and hypertension also, and then we need to take care of those kind of things also. Dr. Mithun, apart from this, actually we will be taking care of that. Do we have anything specially for the fatty non-alcoholic steatohepatitis?
So when we come about the treatment of non-alcoholic fatty liver disease, what I tell my patient and what the evidence says is that the first treatment of non-alcoholic fatty liver disease is diet and lifestyle modification. The second treatment is diet and lifestyle modification. The third treatment is diet and lifestyle modification. So the message should be very loud and clear that as of today, we don't have any approved drug for specifically treating non-alcoholic fatty liver disease. The only way somebody can lose significant amount of fat is by targeting around 7% of weight loss, and if somebody's fibroscan had shown some fibrosis, the reversal of fibrosis requires around 10% of weight loss, which practically very few patients can achieve in clinical practice. Yes, there are some drugs like vitamin E, saroglitazar, and there are some new drugs in the pipeline like obeticholic acid, but none of them have been FDA approved for treatment of non-alcoholic fatty liver disease. At best, they are adjunct therapy when compared with lifestyle modification and diet.
And also the question remains, how long will they take it?
Yeah.
And as you said rightly, that lifestyle modifications will have hardly 10% of the people will really strict, and then they will be very serious about these. For most of the people, especially if they are obese, and obviously obesity is very closely associated with alcoholic fatty liver disease and diabetes. Dr. Abhishek, we have been hearing a lot about this bariatric surgery, and some people call it as a metabolic surgery. What is this all about? How do they really reduce the weight with these techniques? And who is the right candidate to undergo this kind of intervention?
So when bariatric surgery came into the picture, it was basically for obesity. And with time, we realized that it's not only the obesity which is being treated by this procedure, but also it changes the metabolism. And that is why this new term, metabolic surgery, came into the picture. And there is enough literature which suggests that how bariatric surgery can give health benefits. It causes approximately 77% of excess weight loss, 85% resolution of OSA, up to 90% resolution of hypertension, and approximately 83% resolution of type 2 diabetes, and more than 80% resolution of metabolic syndrome. Now, here is the list of all the diseases which are associated with obesity, It starts from migraine and goes till gout. And somewhere, because as Dr. Rakesh rightly mentioned, obesity is a pro-inflammatory state. So wherever there is an inflammation, it's exaggerated because of obesity. And post-bariatric surgery, all these responses reduce because this pro-inflammatory state goes down. Speaking of what are the indication, we all know how do we grade obesity. It starts from grade 1 obesity, which is 32, 35, and goes till super obesity, which is beyond 50. So also Dr. Mithun already mentioned about why Indians are more prone, because we have a lot of truncal obesity and visceral obesity, and because of that Indians or Asians are more prone to develop metabolic syndrome even at the low BMI, and that's why the guidelines for bariatric surgery is different for Asians compared to Western. Now these are the guidelines which are set for Asian. If anybody has a BMI of more than 35 with or without comorbidities, BMI more than 32 with comorbidities, BMI more than 30 with central obesity, which rightly mentioned by Dr. P. N. Rao, with the waist circumference of more than 80 centimeter for females and 90 centimeter for males, and at least 2 criteria of metabolic syndrome, which is raised triglyceride, reduced SDL, increased HDL, hypertension, and raised fasting blood sugar. Now, important point here is if somebody has a BMI of more than 27.5 and an inadequate controlled diabetes, which is more than HbA1c of more than 7, then we have advanced procedure which are specifically designed for diabetes or metabolic syndrome. That's why these two names came, and these procedures are called metabolic surgery. Now, just to clarify, the most common procedures which are being done worldwide now, there are more than 10 procedures, but I will tell you only about the 3 procedures which are commonly done nowadays. The most common is the sleeve gastrectomy, in which approximately 70% of stomach is taken down, which reduces ghrelin, and then this is how the food passes early. The second procedure, which is called Roux-en-Y gastric bypass, which is also called the gold standard procedure, in which we create a small gastric pouch and a small jejunal loop is anastomosed, and this biliopancreatic limb comes and gets attached here. It's a very complex procedure, and let me tell you, all these procedures were done by open technique maybe 30 years back, but nowadays all procedures are done by laparoscopy, and patient can walk within 6 hours of procedure. The other procedure which is gaining popularity is a mini gastric bypass, which is similar to Roux-en-Y gastric bypass, except there is a long gastric pouch, and instead of Roux-en-Y, we just bring a loop of intestine and attach it here. So that's why it is also called one anastomosis gastric bypass. A very important point here, a lot of people think that bariatric surgery will cause weight loss, but let me remind you, diet, exercise, and behavior modification are the utmost importance after bariatric surgery. And as I always say, it's a teamwork which involves all of us who are present here and a lot of other people who are behind the curtain, but they play a very important role. Thank you.
Thank you. I'll send you a patient, then he comes back and tells me that, oh no, I don't want to undergo. I still want to try myself, whether I can do it myself for some time, So, Dr. Rajesh, what do you think the lifestyle modifications which you are going to advise these people? He doesn't want to undergo the surgery immediately. He wants to try it himself.
So it has been shown that those who observe these two things and able to achieve weight reduction with this targeted exercise, or if they are able to reduce 5% weight, and Mithun has earlier emphasized, their steatosis may come down. But to achieve decrease in fibrosis, decrease in necroinflammation, you should target around 10% body weight, 7 to 10% of body weight, and it has to be sustained. So, as an exercise, you have to maintain this weight reduction strategy and with diet and exercise. This is the cornerstone, and this is all the guidelines, whether it is American guidelines or regional guidelines or Indian guidelines, everybody recommends, and this is the crux, the cornerstone of management.
But you mentioned fibrosis, but
Yes.
how do you, the patient doesn't want to undergo the fibrosis even initially and also afterwards. How do you assess fibrosis in these people without without undergoing the surgery, without undergoing liver biopsy?
Yeah, there are several methods. There are several scoring systems, FIB4, which we calculate by certain methods, like we have the blood parameters, and you can calculate, you can collect AST, ALT, simply which we order in day-to-day our clinical practice. You can measure platelet counts, and by the formulas are there. You can calculate these scores, and these scores tell us whether the patient is having fibrosis and how much fibrosis there. Now we have another machines are also available, which are simple machines, but they are expensive ones, so the cost is little higher. So we have very well validated data with the FibroScan, which is available in our institute also and several institutes. And that's a very simple ultrasound-like machine where we can measure the values and which can give a very accurate ideas, which is as good as doing liver biopsy, whether the patient has significant fibrosis or that doesn't have fibrosis or minimal fibrosis. So there are several tools available. Short of liver biopsy, you can do these measures.
Okay, thank you, Dr. Rajesh, for telling us that the simple investigations like an AST, ALT, and the other parameters also give a hint about whether the patient is having liver fibrosis, and simple machine investigations like a fibroscan, and some are ultrasound based scans are there which also can test the amount of fibrosis, and also more expensive ones like an MRI also will tell us how much fat is there in the liver, and also it is going to tell us how stiff the liver has become. Okay, now the patient says he just afterwards he says that I failed in my effort, I couldn't reduce. I tried for 6 months and I couldn't reduce my weight, but I don't want to undergo the surgery also. Do you have anything in between that, endoscopically? Can you do anything, Dr. Rakesh, please?
Yeah, so precisely there's a lot in between. So as it was told by previous speakers, something called as rule of 10, what we say. So 10% minimum weight loss is good enough to have a positive effect from head to toe, what Abhishek has shown in his slides, which will give a positive effect on the cardiac, pulmonary, fatty liver, and osteoarthritis, so on and so forth. So as Dr. Rajesh told, it's very impossible to maintain the lifestyle and then have a sustained weight loss. In fact, there is a famous article in 2017 in NEJ where there was a captured cohort of people from Western population where they have did a RC, randomized controlled trial on lifestyle versus other arm. So where they found only 10% could sustain the weight loss. So we need something which is a minimally invasive or a non-invasive daycare procedures which can be useful to get this rule of 10%. So as you see on the screen, there are some endoscopic daycare procedures which are in vogue from past 5 to 10 years. And I believe this is going to be the treatment of choice in certain subset of patients, not for all, in the next coming decade. As you see on the left hand side of the screen, you have the gastric endoscopic metabolic therapies where you put in a balloon which will give you a weight loss of around 10 to 15% in 6 months. It's a OPD based procedure, hardly 10 to 15 minutes to implant and 5 minutes to explant. This will give you a weight loss of around 10 to 15%.
Then you have other devices which are coming slowly up, and they also have, which we regularly do, something called as endoscopic sleeve gastroplasty, which is like the laparoscopic surgical gastrectomy, which our bariatric surgeon was telling, which is a suturing of the stomach and decreasing the volume of stomach, which gives around 20% weight loss. Again, a day care procedure, hardly takes 30 to 45 minutes. And this has got a little robust weight loss more than the balloon. So this is about the obesity patients, obese patients having weight reduction. On the extreme right is the small bowel endoscopic therapies. This is basically for people who have got diabetes, and as Dr. Rao told, the diabesity, which is now the disease in the next decade, with NAFLD or NASH. So to address that, we have the small intestinal devices, which again are OPD based procedures, where they'll have improvement in the HbA1c by 1.5 to 2%. And we are kind of pioneers in the world doing research on these devices, which a few are into the commercial market. So if you see the slide in between, that is where the whole seminar is about the non-alcoholic fatty liver disease. So either of these devices, which can be at the stomach level or at the small intestine level, they have positive effects in terms of affecting at the gastric pathways or the small bowel pathways, and where the gastric pathways will be having an effect on the weight reduction directly and indirectly on the metabolic parameters, whereas the small intestinal pathways will have a direct effect on the metabolic pathways and indirectly on the weight related pathways. So our future, what we foresee is, if you combine these two, the gastric and small intestinal pathways, with these devices, which are a minimally invasive or a daycare devices, we are going to address the obesity, diabetes, and NAFLD, or the metabolic syndrome per se, which we call MAFLD rather than NAFLD. So this is going to be the future, and we are already in the race. And as of now, we have pretty much established trials and also established evidence. In fact, we have our own series of 100 patients where we did this endoscopic sleeve gastroplasty and measured the fatty liver component pre and post procedure, where we found significant improvement in the parameters in terms of fibrosis score reversal and as well as the liver function test parameters. So I think we have a lot to do in between this lifestyle modification and the bariatric surgery.
Okay, thank you very much. I think we had a very good discussion. Let me summarize for you. Don't be afraid of fatty liver disease, and don't neglect it either, both the ways. And it's not just limited to only liver alone, and we have discussed that the people are at a higher risk of developing the cardiac issues, and also lung issues also can develop. And by doing simple investigations, and Dr. Mithun and Dr. Rajesh Gupta has told you that simple investigations like a liver function test and a fibroscan can tell you that the liver, the NASH, that is non-alcoholic steatohepatitis, has arrived, and therefore you should be careful about. And initially you have got only simple lifestyle modifications apart from treating the diabetes, obesity, and the lipid treatment for the blood lipids and for the cardiac issues. The lifestyle modifications they have to be taken very seriously, but unfortunately the people, only hardly 10% of the people will adhere to this kind of a thing, and therefore you do require some kind of a pharmacological management, which Mithun has briefly told you, but then they are not enough. And therefore in those people where they are still obese and diabetic and they are unable to achieve their goals by the lifestyle investigations, then we go for the bariatric or a metabolic interventions, either by the surgical methods or laparoscopic methods as told by the Dr. Abhishek, or by endoscopic methods as detailed by Dr. Rakesh. So the dictum is that don't be afraid of fatty liver and don't neglect it either, and it is a multi-system disease. Thank you very much. With this, I thank all the panelists who have contributed their expert opinions in this particular field. Thank you.